it's going to be a shorter one than the last one that we did yesterday, because we're going to be dwelling solely on we're going to be dwelling solely on much of the things that have to do with the what's it called, the ideal methods of scanning, how we're supposed to put our probes and all of that. We dealt with all of the anatomies yesterday, and then today we're going to be dealing with just all that is entailed in the procedures. Yeah, so it's going to be pretty short, not so long. Yeah, but then it's still going to be pretty insightful. So let's get ready for something fantastic. Is that okay? So, um, ocular ultrasonography, point of care, how to do it most efficiently, and that's what we are about to talk about. So we begin. So on today's discussion, we're going to be talking on the procedure, the procedure, and then we're going to be talking on the reporting, the procedure, and then we're going to be talking on the reporting, the procedure, and then the reporting. So, first of all, I will be guiding us through how an ocular scan ought to be done. I'll be guiding us through how we ought to perform this procedure, how the protocols we're supposed to use, and also to how it's going to be carried out. A lot of people just put the probe on the eye, but then a lot of things are not done the most appropriate way. A lot of things are not done the most appropriate way. So what I'm going to be doing today is showing us exactly what we need to do to be able to get the most optimal, the most optimized image, and the images that give relevant information for clinical interpretation and management. Is that okay? And so in demonstrating the ocular scan, the first thing you need to do is to prepare the patient, and then a video is going to follow um, this particular demonstration that will be on the YouTube page. We can go through it. It's going to be called Ocular Scan Demonstration. I'm going to make reference to it for those who want to what's it called, see a live demonstration of how an ocular scan is done. You can make reference to the video. It's going to be a practical video that shows you everything I am talking about right now, and it's also going to show you a demonstration of it's also going to show you a report template as well. And so you can go through it. Once this lecture is done, we're going to be seeing the video on the page. So prepare the patient, ideally in an excellent manner, to achieve excellence in your in your investigation. The first thing you need to do is to introduce yourself to the patient and also confirm the patient's name. Is that okay? You explain the procedure to the patient and obtain consent. Tell the patient, I'm going to do this for you. I'm going to be checking your eyes. A lot of people, it is only you that knows what you want to do. The clients might not know exactly what is expected of what to expect from investigation. So you have to not assume for them. Let them know, like you can see in this red circle, this place here, you can see the doctor explaining to them what they're going to do. Then the third thing you have to do is to position your patient. Anybody you are going to be doing an ocular scan for is going to be lying in the supine position. They're going to be lying in the supine position. And so in this setting, it's advisable that also you make sure that the eyes are closed gently. There are some that do it advisably, do it with the eye closed. Is that okay? To avoid irritation by the gel, it's inert, but nevertheless, to avoid it, and also to avoid any form of irritation with the probe, just make sure the eyes are closed when you are performing this procedure. Then ask the patient to minimize eye movement in the scanning, except if it is required. Is that okay? Um, those are the things you need to do. Now, remember, we are talking in this point of care setting, we are assuming that what we are going to be using will be our linear probe, because the what's it called, the specific assigned ocular B probe that has the A mode and the B mode will not be available in most clinical settings. It will be the linear probe. So in the course of this particular deep dive point of care ultrasound series, we are going to be assuming that we are using the linear probe. Is that okay? So after introducing yourself, explaining the procedure, positioning your patient properly, and asking the patient to minimize eye movement during scanning, we go into the next step where we prepare the probe. And so, like I said, in this case, we are going to be using the high frequency linear probe. You are supposed to apply, take note of the word, generous coupling gel over the closed eyelid. Generous coupling gel over the closed eyelid. So look at the way this gel is applied. This is how you're supposed to do it. This is not the procedure where you just put a small gel over the eyelid and then you think that you're going to get the best. No, you're supposed to put generous. And I'll show you what generous means in the next slide. The next thing you're supposed to do is to set up your machine, your presets. So you are supposed to use the ocular or ophthalmic preset on the machine if available. If you go to linear probe, some people have the ocular or ophthalmic presets. If that is not available, the next best preset you should use is any preset of a superficial or small part. So for example, you find testicular presets, thyroid presets. Yeah, the point of care setting, if you have those kind of presets, those things offer the presets are specifically designed for what's it called, high resolution superficial structure, high resolution superficial structures. That is, those presets are meant to work best to see things that are superficial and give high resolution to it. And so since the eye is also like that, then you're going to be looking for something that offers such a preset that will offer such kind of um um you know, such kind of thing. Is that okay? So that's what you need. So remember, I said generous gel. This is a selfish way to apply gel. You're not going to get so much if you apply gel this way. I'll tell you, in this particular patient I'm trying to scan, I'm applying it generously. The gel is applied generously. Sorry. Okay. The gel is applied very, very generously. It's very important. The reason why we apply this gel very generously, in which you would also see me demonstrate in the video tomorrow, is that when you are placing your linear probe on this client, number one, you don't want to mount pressure on the globe of the on the globe. Why? You don't want to cause pain or discomfort or break the globe anyway, or rupture it. And obviously, it doesn't get there, except if one is actually trying to be incredibly wicked. You don't want to rupture the globe. Very importantly, number two, apart from causing pain and discomfort, if you apply too much pressure on the eyelid and that pressure is transmitted to the globe, because you would observe that when we apply copious gel this way, in the right way, what we expect is that when your probe is going to be contacting this gel, it's just supposed to be on the gel alone and it's not supposed to touch the eyelid. So the probe is supposed to just touch the gel, but the probe is not supposed to mount pressure on the eyelid at all, such that if you're looking at the screen, there is a gel interface before you see the eyelid. That's the ideal way the investigation is supposed to be done. But if you're putting this small amount of gel, what you eventually end up doing is you have to now put pressure on the eyelids, and then that pressure is transmitted to the globe, and that kind of compresses the globe. In that instance, many times you will get false axial diameters because now you have a flattened cornea. And then when the cornea is flat, and when the cornea is flattened, when it's flattened, it reduces the diameter, the axial diameter, and so you get false axial diameters. However, when the gel is this cold, you put just sufficient, you put your probe just on the gel, and then you have an interface. You don't even need to put pressure at all, just a touch of your probe on it. And then you are able to see all of the structures very, very clearly. So please, copious amount of gel. Don't spare, but at the same time, don't waste. So, and the next thing you're going to do is to perform the scan. So see the way he puts the probe on this particular patient's eye with the pointer facing where the ear is, which is what is supposed to happen. So you're supposed to place the probe lightly over the gel, over a closed eyelid. Avoid pressure on the probe. And then if you do that, you will see this. We'll see it more clearly in the video. Adjust the gain orbit very clearly. You're supposed to adjust your settings properly. Then center the probe over the periphery for eccentric views. So what we're just trying to say is that if this is the cornea centered around here for axial views, is that okay? Towards these directions. Is that okay? So you can angle it towards the periphery for eccentric views. Can obtain views in the longitudinal, exactly, transverse, and oblique plane. But there is a limitation to this when you are using a linear probe. It many times has a large footprint. And so because it has a large footprint, that is very wide, you might not be able to manipulate your probits, and having limitation to the kind of images you're going to be seeing. Is that okay? All right. So the kind of images you're going to be seeing. So sorry. So all of these manipulations are better achievable with a small footprint probe. Is that okay? So at best, if your probe is what from experience in the point of care setting, if your probe is just on transverse, you are able to, and it's this way, you're able to at least capture much of what you are looking for. Just angulating it, just like I told you, in more eccentric views, will even give you much of the full details. Then, when you are trying to do dynamic assessment, what you're asked to do is to move the eye gently in different directions. And that will be if you are probably trying to check peripheries, or you are probably trying to check the sides of the eye. So you can tell the patient, this is during dynamic assessment too, to move the eye this way, just the eye, to see the medial aspects more clearly, move towards the medial aspect to see lateral aspects more clearly, raise it up superiorly to see inferior aspects more clearly, pull it down inferior to see superior aspects more clearly. That is if there are things you are interested in those areas for dynamic assessment. First of all, if you have placed the probe over the eyelid, under above copious gel, and then you adjust, what's it called, following the adjustments of your gain and depth, you should be able to capture much of the details in the eye. So look at this is many different ways in which the probe is being positioned. This is a small footprint probe to get different axes, the longitudinal, the axial, is that okay? The transverse scan, is that okay? And so we're seeing different things. But this is best done with a small footprint probe. So now, haven't talked about how to place your probe. How do you evaluate? What are you looking for? The key is this: evaluate systemically. Evaluate systemically. And what I advise that you do is do it from superficial to deep. It helps you not to miss a thing. So, and begin first with the eye that appears clinically normal, then proceed to the contralateral eye, the eye that has the issue. So if both eyes are normal, then start with the right, which is often more convenient. Is that okay? And how do you move? For each eye, scan in an orderly fashion from superficial to deep. And so, where do you start from? You start from the eyelid, up top, superficial. And remember what I told you the eyelid looks like: hyperechoic, hypoechoic, hyperechoic. The conjunctival border, the what's it called, the outer border, and the orbicularis ocular in between. Is that okay? Take a look at it. How is it looking? Then move into the next thing, which is the crescentric, echogenic, thin cornea. Then after that's why the anatomy was so beautifully key yesterday, because I was trying to let you see the pictures of how you're going to be moving. Then after the cornea, remember I told you that you're going to drill a hole into the cornea, you enter into the anterior chamber. Yes. So the next thing you're going to be doing is you're going to be looking at the anterior chamber. Is that okay? You're checking the anterior chamber, which from the sonographic anatomy we know should be naturally clear. No issues inside. Then we are moving through the anterior chamber and we're trying to look at the back, the posterior boundary of the anterior chamber, and we see the iris, which is the posterior boundary. We should see that echogenic iris. It usually has a central aperture, which is the pupil. If you move your probe, angulate it a little bit, you should be able to appreciate the pupil. Sometimes, sorry, exactly. And then as you're appreciating your pupil, sometimes you will be seeing the anterior border of the lens coming through, visible along that same plane. Is that okay? So you examine the iris and you also look at the lens. So systematically we are moving. We're not just going haphazardly. Is that okay? Then after doing that, we move down to the next thing, which is the optic disc. Think on it. Think about what is going on. Make up your mind what's going on there. Are there echoes inside? Is there any retinal curve there? All of this, you're looking at it. Then the last thing you look at is the optic disc and the nerve. Okay, not the last thing anyway. The last thing within or closely associated with the globe. We look at that. Then after looking at that, then you now look at the periphery of the eye, what surrounds the eye, the orbital soft tissue and fat, any fluid, any collection, any mass, any foreign body, you are looking at that. Then you now look at the VC many times with dynamic assessment. Is that okay? So that's very, very key. So you've whatever the gel, not as much as possible, not contacting the eyelid. So you have a layer of gel even before the eyelid to be able to appreciate the movement of the eye. the outermost part of the eyelid. Then you appreciate the cornea. Then you appreciate the anterior chamber, the iris, the pupil, the optic disc, and the muscle. Is that okay? Then after you do that, you use the same probe settings and patient positioning for the other eye, the contralateral eye, to allow for direct comparison. And then if there is any asymmetry, you document it. So in more detail, let's look at what you would find when you are looking at many are looking at all of those structures. This will inform what is normal so that you can know what is abnormal, and also this would also help you know how you should describe what you are seeing in your report. So when you look at the eyelids, you should see two gently curved parallel echogenic plates separated by the thin hypoechoic band of orbicularis oculi muscle, just like we saw in the sonographic anatomy. So you have the outer part of the eyelid, you have the inner part of the eyelid, and then in between there is a hack, and that is the orbicularis oculi. The first thing you see when you're supposed to take note of that. Is that what you have? Is there anything different? Note it. Then after that is the thin echogenic line between the eyelids, the cornea. Then do before you move into what's it called, the anterior chamber, take the axial measurement of the eye. So that means you are going to be taking from the outer cornea, like I told you yesterday, to the inner surface of the retina. Sorry about my eye. Retina. That will give you the axial diameter of the eye, which I mentioned is usually between 22 and 25 millimeters. And between the axial measurements of both eyes. This is not kidney we are measuring here. This is not testicle we are measuring here. The eyes have similar diameters. If there is any asymmetry, you need to let us know about it. It's very important. Excuse me. Sorry for the breaking transmission. Okay, so the next thing you're going to do is now get to the anterior chamber. Check out the anterior chamber. How is the anterior chamber doing? And is it clear and echoic? Yes. If it is, then the next thing you ought to do is to, what's it called? Is to measure the anterior chamber diameter. You can decide to do that. Measure the anterior chamber diameter. Then after that, you take the iris and the pupil with subtle rocking, sweeping movements, like I told you. Observe the ring-shaped iris and the pupil with subtle rocking movements. That will be able to make you visualize the iris across all planes. Is that okay? Then the next thing you should observe is the lens. What are you looking at in the lens? You're trying to see its position, its shape, and its echogenicity. Think about those things I said. This position, is it in the right place or is it dislocated? Its shape, is it properly shaped? And its echogenicity, is it anechoic inside with thin echogenic posterior boundary, or is there something else? Those are the things you are looking at. You are not really bothering yourself about its measurement, basically. Then the next thing you are going to be thinking about is the vitreous humor. Observe whether it's anechoic. We're not really bothered about its own measurements too. Or if there are any echoes present. Observe for hemorrhage, membranes, or foreign bodies. Very, very important. Observe for any of those things, hemorrhage or foreign bodies. So you're not supposed to have foreign bodies inside. You're not supposed to have hemorrhaging inside. You're not supposed to have any single internal echo inside. It's very important that you observe for that. And if you see any of those things, there are firmly attached, there is a detachment for the retinal choroid scleral complex. You're supposed to have a concave or a smooth concavity bordering the perimeter of the vitreous. No bumps, absolutely nothing. As you can see in this image here, no bumps whatsoever. Observe for any. If there is any, note it. If there is any, note it. And then observe the optic disc. Look out for bulge. When you get to the optic nerve, measure the optic nerve sheath diameter. Measure it. Measure the optic nerve sheath diameter. And then when you get to the optic nerve, you can just put some color on the optic nerve, which tells you that there is the ophthalmic vessels are patent and vascularity to the eye is intact. Then the last thing you're going to observe is the echogenicity and echo pattern of the soft tissue. Look out for masses, look out for asymmetry. Very, very key. So I've repeated these things again and again for us to know what to do. Then after you have done this, the next thing you're supposed to do is to document your findings. Note the abnormalities in the observable planes. Save the sign loops when necessary. Note both normal and abnormal findings. And then the last thing you're going to do, the last step, is to conclude with an impression. Summarize your key observations and state the diagnosis or exclude major pathology. How do you report? Very simple. A standardized ocular ultrasound report ensures that all relevant anatomical structures that we checked for are systematically assessed and described in a clear, reproducible manner. So by following a structured format, the report remains scientifically accurate and comprehensive, as well as being clinically useful. So follow these steps to know how to correctly structure and write a ocular scan report. Number one, begin with the indication. State the indication. So indication number one, this scan was requested to evaluate suspected retinal detachment, or this patient had leukocoria, or this patient trauma to the eye, whatever. Then the next thing you're going to do is to describe your technique. What are the components of your technique? You are mentioning important things as the patient positioning, the probe you used, is that okay? And the place you scanned, along which you took your images. So this patient was scanned in the supine position with the eyes closed. Is that okay? With copious gel applied, and with a there. Is that okay? And was and then the planes that were the orbital structures were assessed across the longitudinal, transverse, and oblique plane. Again, I'll say it again. This patient was scanned in the supine position with a closed eyelid, upon which copious gel was applied. a high frequency linear probe was used. Is that okay? And then all sonographically relevant ocular structures were obtained across longitudinal transverse or were obtained via the longitudinal transverse and oblique plane, whatever. You know what I'm trying to say? Describe your key techniques. Is that okay? Then the next thing you're going to do is to report your findings systematically. Key commentary and vital measurements are the two important things in an ocular scan. Key commentaries describe the observable anatomy of each structure and any pathology present, while vital measurements help to quantify structural dimensions, compare symmetry between both eyes, and support accurate diagnosis and follow-up. Whether you want to do both eyes at the same time or you want to do right eye and left eye, depends on you. But every single part of your anatomy, or every single part of your report that has to do with the eye must be described with some key commentaries and with the measurements that are important. Vital measurements should be placed alongside the structure being discussed. For example, when commenting on the optic nerve and when commenting on the optic nerves, make sure that you are commenting at the same time on the optic nerve measurements, the optic nerve sheet diameter, or whatever you're going to be taking that the doctor requests you from. And it should be put at the same point. Is that okay? Make sure you do that. It's very, very key so that the report doesn't get scattered. And then if you are going to be making key commentaries, in what areas should you be making comments on? What areas should you be making comments on? What areas should you be talking about? Remember, is the same way you are going to be systematically making your comments. Start from talking about the eyelids. The eyelids appear this. Eccentric shape cornea, describe it. The anterior chamber was clear. The iris appeared normal. No lenticular opacity, and the lens was in its what's it called, in normal position, wasn't dislocated. The vitreous was clear. Retina sclerocleral complex, you describe it. Describe the optic disc and nerve. Describe orbital soft tissue and fat. Talk about the extraocular muscles in that order. Talk about it in that order. And then when you're talking about the cornea, when you're talking about the eyelids and you're talking about the cornea, and then when you're talking about the anterior chamber, at that period, at that point, you can mention the axial diameter. We're talking about the optic disc and nerve. You can talk about the optic nerve sheet diameter in that area. So for each structure examined, report the observable anatomy. Describe the icogenicity, contour, integrity, and relative velocity. Specify its location, extent, echogenic pattern, and its relation to surrounding structure. Is it mobile? Is it moderately reflective? Well, what's it called? Is it a moderately reflective membrane seen in the vitreous cavity, suggestive of a retinal detachment? If a pathology is observed in one eye, immediately comment on the contralateral structure to document whether a similar or related abnormality is present. For example, you see something in the retina, you see a particular membrane, you've described the membrane. Next thing you should measure, contralateral eye appears normal. No similar pathology can be demonstrated in the contralateral eye. Is that okay? It's very, very key that you say that. Then after we talked about it, but just to put in your vital measurements. And what are the key measurements we are looking out for? Number one, the axial diameter of the probe of the globe should be between 22 and 25. Can take the anterior chamber depth. That is also nice too. This is measurement. Then the next thing you should take is your optic nerve sheet diameter. That's also nice. Take it. Then the next measurement you should take is the measurement of any visible pathology. or any visible mass take its extent, its limits. Is that okay? Is that okay? So note this. Alternatively, each eye may be discussed or documented individually, ensuring that the right and the left eye findings, including key commentaries and vital measurements, are clearly separated for clarity and comparison. To discuss and document each eye individually. Is that okay? Or you can choose to you want to talk about it together. But for the sake of clarity and for people to for the person that will be interpreting to see what exactly is going on more appropriately, differentiating the right eye from the left eye, I advise that you talk about them separately, except if you have a very normal scan. You can be very, very dynamic in how you arrange your report format, but make sure that it comprises every single thing that we have talked about. And with that, I'm going to say thank you for listening to this brief presentation. What will follow shortly on the page will be, in fact, just look at the comment section, the link that will have the live demonstration done. Is that okay? And a report format that what's it called, I can recommend for you. So do that, and what's it called, holography. We'll continue with key pathologies tomorrow, talking about what you will be finding as pathologies in many of these scans that you get to do commonly at the point, and that you will encounter at the point of care. But for now, have a wonderful evening. Cheers.